Thank you very much. Thank you, Spanos. Thank you, Dr. Katsanos, for inviting me here today. It's a pleasure to talk to you about this a bit of a provocative also talk, percutaneous AV creation, new player in the game. So these are my conflicts of interest. And this is what we are used to see, you know, these are the typical percutaneous AV fistula creation sites with wailing or ellipsis, but still we are missing the king of the fistula. So we are missing what the guidelines, even in 2019, confirm as the first access for AV fistula. It's radiocephalic fistula, and today we're going to present ePath, which is a system that possibly can really work together with other two systems in delivering good care for our patients. So it consists of a system made by two different parts. One, it's the target device, which is a 3 French size, and the other one instead is the crossing catheter, 5 French. The crossing catheter goes on an 014 guide wire, where the target device instead is equipped with a snare, which works as a target, and also there's a snare control, which can be, of course, open and closed in order to deploy the snare. And on the launch catheter, there are printed electrodes, and of course a nitinol crossing needle, which is used to cross the vessels. There's a needle which can be regulated in depth in order to reach, you know, vessels which are closer or far away. And there's also the possibility of course, to push the needle with quite a good effort in order to have good pushability for the needle, which is, I think, is a great thing. Electronic alignment, how it works. There's, of course, as you said, the crossing catheter with the needle, and it aligns by imperceptible electric field with the target catheter. And of course, you know, there are different angles of alignment. So when you rotate the two devices, or at least you rotate the launch catheter, then it tells you more or less exactly with, no more or less, it's with a very exact accuracy where when the two devices are aligned. This guidance is not affected by any kind of contrast, so you don't need to use contrast in order to see where the devices are, like with the other crossing devices, and there's no need for any additional X-ray exposure. If you look at how it works, it's in vitro. You can see here that's the screen that it's equipped with the device, and you rotate the device till you reach the green, let's say, screen, and it's sort of, I call it dump-proof. Then you advance the needle. The needle usually goes through the snare, and the wire goes through the snare, and then you are able to capture the wire to make the connection. So of course it's like this is in vitro, so people can be skeptical about this, but this we're already done in vivo in human beings for lower limbs recanalizations. You can see here this was a complex case of recanalization with two different accesses, antegrade and retrograde. There was dissection on both sides, and you can see I deployed the needle. You can see the screen here, which I use for guidance. I'm advancing now the wire, and you can see that the wire on the top left of the screen is advancing nicely into the distal part of the popliteal artery after, you know, crossing this dissection with great pleasure of everyone. First shot. Of course, you know, now we're not talking about lower limbs, we're talking about fistula. Today the Congress is about this. So let me show you the cadaveric wrist endo AVF that we performed. So there's, of course, target device access, and as I said before, is a 3 French sheath with a snare, and it's achieved at the level of the brachial artery in our study. Crossing catheter access, you see with you know, the main device is inserted through the cephalic vein through a 5 French sheath. And you can see here, this is exactly what it looks like in the cadaver. You can see the radial artery on the medial side and the cephalic vein on the lateral side. And you can see here that, of course, you know, we move the catheter exactly like you have seen in vitro, with the successful alignment straight away. It takes like 30 seconds. Successful deployment of the needle, the first attempt. You can see here the needle coming out, 1, 2, 3, out. It goes through from the vein into the artery. You can see now I'm advancing the wire in order to cross the vessel through the snare. You can see here my wire, 014 wire, goes very easily through the palmar arch, through the snare. At that point, of course, you retrieve, as we said, you know, there's a snare, so you can close the snare and pull back the guide wire. in order to access the vessel from through, and then you deploy the balloon at the level of the guide wire between vessels, and the balloon is expanded in order to create a proper channel between the two vessels. You can see here that after we perform the angioplasty, we deploy the small bare metal stent, and we injected contrast. You can see that the fistula between artery and vein is created. Of course, the flow is not great because it's a cadaver, so it still has some limitations. Of course, the fistula then stayed patent all the time that we injected, so it was like consistent flow with no extravasation at the final angio. You can see here that we, in another arm, we also perform a fistula, which was more proximally at the level of the radial, proximal radial. You can see here the vessels were very far apart, and we actually performed the re-entry in vessels which were not completely parallel, which is, of course, the best case scenario. So this device is able also to cross in what we call difficult anatomies, and we deploy the cover stent, and as you can see, again, fistula created with no extravasation. We did also some animal models. So we of course we took sheep's, as you say, ovine model. The fistula was created again with vessels which were far apart, sort of 4 millimeter apart. You can see here on the ultrasound that we did 4.4, and ballooning was performed again with standard angioplasty with nothing else, and we created this channel with, after dilatation with a 3 millimeter balloon, was consistently at just above 2.5 millimeter, and there was a very good flow with no hematoma formation whatsoever between the vessels. So the flow was sustained in this kind of in vivo animal, and there was no significant hematoma. Of course, like we have many doubts. It's a technology which is at the very beginning. We need to understand if the size of the vessels in the future can limit us in some way. If there's any bleeding at the level of the anastomosis, because we don't know if in a human being there could be an hematoma formation. Primary patency rate. Do we need to re-intervene soon? What will be the primary patency rate? Hopefully not. Gelling of the radial artery. Is this any problem, especially if we use stents? And this is where it comes with the stent. So, okay, you might be scared, about users of stent, but I'm really not. You can see some publication which show that the stent for just anastomotic AV stenosis are very good. You see 68 patients here, 97 success rate, and assistant patency is 90% at 2 years and 80% at 4 years. So, they say that just anastomotic stenting is an effective technique for maturing and maintaining the fistula, even better with supera stent, as shown us by Dr. Thomas, 42 patients, rescue of the fistula, and you can see the primary patency rate at 2 years are very high, 98 and 93%. Of course, even the stent just changes the geometry and give you even a better flow, as demonstrated by this analysis. So the future, of course, we need to do more acute and chronic animal studies. We need to do first in vivo, and hopefully it's going to be done in the autumn. And, it doesn't matter really at the end of the day how you treat the patient, but it's important to say, as Patch Adams says, you treat a disease and you win, you lose. But you treat a person, and I guarantee you, you will win, no matter what the outcome. And with that, I thank you for your attention.